And now I would like to welcome our following speaker, Dr. Martin Wullschleger, who is a Swiss and Australian qualified general and trauma surgeon, currently appointed as the Director of Trauma at the Royal Brisbane and Women's Hospital. Apart from his clinical passion for trauma patients, he is a recognized trauma leader with expertise in trauma system development, and he holds the position of the clinical chair of the statewide trauma clinical network in Queensland, as well as the academic activities with broad trauma research interests and international experience in both AQS and DSTC courses. Dr. Wullschleger is heavily involved in several trauma-related committees within the Royal Australian College of Surgeons and the Jamieson Trauma Institute. He was a former competitive national gymnast in Switzerland, and he still plays the accordion on festive occasions. And now we'd like to invite Dr. Wullschleger to give us a talk on entering a new normal, its impact on the management of trauma. Dr. Wullschleger, please.
Thank you very much for the invite. It's a real pleasure to be in this webinar. I have attended a number of times, and it's always just insightful and just apart from entertaining, but really deep insights into our trauma management. So thank you very much, and I feel honored. So basically, you might wonder what this is all about. And when I discussed the topic, I thought, well, why not talking about the COVID pandemic and trauma, its impacts? But then I very quickly had to go very humble, and I come to that fairly soon, because we actually, here in Queensland, in the northern part of Australia, we actually haven't really seen a pandemic. And I guess we're entering now in a sort of a new phase. We just opened the borders to the other states 2 days ago, and we planned a lot. And I just want to take you a bit on a journey of those couple of years and how that impacts trauma management. Just in terms of some declarations, it's really my talk, and also from particular experience which I gained as the Director of Surgery at the Gold Coast University Hospital at the time when COVID all started. Was also the lead of anesthesia, ICU, and the whole division of surgery. And with that now, being also the chair of the statewide network for trauma, I'm now also leading the COVID response in terms of trauma for the state in this new era. And I have to say, and I'm probably the only one on screen that has no personal experience with any COVID infected patient. I have seen them, but I have not managed, not operated on any of them. So you might say, oh, what he's now going to share with us. So I come from a very different angle, but I hope that you will see where we're coming from, and also you might take this or that into your practice, and I hope you will as well. Some acknowledgements for Michelle Jeffrey. She's the Queensland Trauma Coordinator, Professor Kirsten Walmore, Dr. Matthew Hope, and Dr. Trent Lipp, who gave me some slides and some stats for the talk. So if you look at this quite busy resuscitation room in an emergency department, I think it looks very different nowadays. And even with us, we wear masks, and we try very intensely to reduce the crowd. We've spoken about crowd and noise control for years and years, and there we go. It sort of needed a pandemic to reduce people and show that we can actually still do good management with very similar outcomes. And sometimes even better outcomes, I would argue, with a smaller amount of people. So it is very different. And so I just want to talk to you about our journey in Queensland from a statewide view with some stats, and then talk a bit about how we prepared, what it actually means, the new normal for us, and then its impact on trauma management. Now in Queensland, we have in total, and Queensland has 5.2 million people. It's on the east coast of Australia in the north, and it actually is about 2,000 kilometers long and about 1,000 kilometers wide. So it's a very, very large place. And it's quite unique because we have actually a fair bit of centers even along the coast. It's not just Brisbane. So, and you see we had a bit more than 2,000 cases of COVID, but only 500 locally acquired over the whole 2 years period. And the highest number one of the locally acquired one, the first wave, was really early last year, around April, when we had our longest lockdown as well. And since then, we have barely seen any local transmitted cases. It was just people that flew in with COVID, and now more and more that come from interstate as well. So we had those stats, and this is today's stat that the Queensland government puts out every day. So we currently have active 50 cases. No one is in ICU. Of the active 50, 28 are in hospitals. We have only 7 deaths. So I guess particularly from the death perspective, I guess it has worked out. But yes, the community, the population is quite nervous. And a lot of professions, a lot of people actually struggling, so it's really a balance act. And I get a bit more into it why we went that way. Just a brief. So that's my hospital where I work in, Royal Brisbane Hospital, and you see there are 2 lines. Here is one line where people line up. That goes up here and around the corner, another corner. That's the fever clinic. So that was on a day when I had to go across the road for my statewide commitments. It was on a lockdown day this year in April. So it just hit a few community transmitted cases. We went on a quick lockdown, and it stimulated really that a lot of people went to the COVID test who felt slightly sick, just had a bit of sore throat and so on. And the other line is vaccination line. So we had both lines lining up for sometimes hours really to either get tested or get their vaccination shots. And that illustrates for me a sort of bit where we were up to throughout those times. Now back to the Queensland journey. It was really a strategy of elimination. And it was a quite strong joint venture between infectious disease specialists. It started at the Gold Coast, where I worked at the time, with public health, who at the time I thought, what are they actually doing? I wasn't really aware how important public health is. But very quickly a partnership formed, and on daily meetings, the Director of Public Health from various places were included in the hospital emergency meetings with all the department heads and so on. So that was really very important. And the tracking, screening, quarantine advice, and running it all, the coordinating and all. And then it was a lot of interaction also with the hospital and health services. A lot of nursing staff and admin staff was actually then released to help with tracking and so on, and quarantine hotels as well. And then we had several HEOCs, so that's health emergency operation coordinations locally, and then also on a statewide level. Then pandemic plans. Yes, we did have pandemic plans, and they didn't look so solid, but in hindsight, they were actually, at least for a start, really, really solid. But obviously they evolved, and locally and statewide really merged a lot. And then the last thing was, I guess, the politicians together with Health Minister. They had lots to say and make some decisions, and on a number of occasions people really didn't agree, particularly get lockdowns and so on. And the slogan was really keeps Queenslanders safe, and so far it has worked out. But yes, a lot of people did suffer and still suffer from it. One important point why the Queensland government went so rigorous with lockdowns is really to protect the regions. And I highlighted it before, we have a number of regions. They have 100, 200,000 people living around communities, but they're far away. They're 500, 600, they're 1,000 or 1,500 kilometers away from Brisbane, from the center. So if they would have fallen over with COVID, it would have been really, really difficult for the state to manage. Reasons for success, as I said before, we were really early on with interventions by public health and health services, and really statewide coordinated with the plans, and was expert-led, by clinicians-led, which I strongly feel is very important. Some of the new facilities in Sunshine Coast as well, Gold Coast, they have infectious disease units with lots, like a whole infrastructure that was built for a pandemic. And the infectious disease director at the Gold Coast at the time, just a few months before it all started, thought, why did we build this facility like that? It wasn't really convenient, built for normal usage, but there we go. It was really well used now. And then good leadership by clinicians, but also by the government, and good interaction with good communication, information flow, coordination. And we had a number of early, but also short lockdowns, which helped. Public compliance, you saw the queue up for the testing as well as the vaccinations. So that was, and I would have thought in general that the Queenslanders are not so compliant, but they actually were quite compliant, which is, it's in hindsight really, really nice, and I guess hold us together as well. The geography, it might have helped because we are quite spread out. But having said that, in Brisbane, there are 2 million people living very close together. The climate, we went into winter and then into the long summer. It might have played a role as well. At the bottom line, I guess, it was luck or blessings that really helped us through. A few stats in terms of trauma, that's from the Jamieson Trauma Institute, and that was really cool that they could concentrate on the data and still do. So while the clinicians were actually going through, preparing and going through the pandemic, they straight away came up with data and so on. So you see here some early data where we have a decrease on injury presentations the first few months, and then it slightly compensated then in comparison with the year before. And here, that was the state, and this is just our health service very similarly. In terms of road trauma in Queensland, in all state, so we had this dip in April, and then it went up again. Just in terms of car and vehicle accidents and victims with hospitalizations, you see again here a dip, and interestingly with motorbikes, motorcycles, it really didn't have a dip, and it actually spiked a bit later. Why? I don't know, but it's really interesting. And then the last slide here on the stats, it shows that in those first 4 months, we had some more, as I guess predicted, some more self-harm, people struggling, in particular in the early decades of life, and then more in the midlife decades, we had more assaults. So that's self-harm, and then the assaults started to peak, and they're still quite high, unfortunately. Our own data at the trauma center, quite nicely, the first dip, so that's the 4 years, the 2 years before and the 2 years since. So you had a dip, and then every time it fell down was a short lockdown, and then also in 2000, just this year, early in February, a lockdown. But since then, it actually has been really quite constant, our work. Because we weren't so impacted, I guess we could also look into pandemic opportunities. And one thing was, particularly during the lockdown phases, we had reduction of elective surgeries. So we had more access to actually do our emergency surgeries. And one of the case study from the trauma center across the river, thanks to Dr. Matthew Hope for this, that really showed they always struggle with the clearance of emergency cases. In the COVID period, they had rather more percentage of patients that needed emergency surgery, in particular orthopedic trauma. The number rather a bit higher, but you can see they were staying far shorter in hospital for two reasons. First of all, because they were operated earlier on and therefore had less complications. They stayed not as long. They were also really treated in good hours, managed by consultant surgeons often as well, which had a reduction in overall of 1 day, which the administrators, the executives really liked. So that's a reduction of costs as well, less bed usage, but most importantly, the patients did better as well. The other opportunity was really to simulate, do a lot of simulations. As I said before, we haven't seen trauma patients that were COVID infected, so we had to train ourselves up. So we did a lot of simulations. And really across the state, we got a fair bit of momentum for emergency surgery, which is great after decades of struggling that only focus was on elective surgery and all those numbers. We're now getting really more momentum for emergency surgery, which is fantastic. So how's the new normal looking like? Basically, I guess it's really as part of normal life, normal professional hospital life, that we see COVID patients and non-COVID patients. And for us, it really means that from the elimination, we move towards the suppression strategy. I'm still a bit curious how it's going to work, because just now our premier is on edge again with just a number of cases that flew in last night from other cities in Australia, but see how we go. But basically what it means that we find two separate patient pathways through the health system. And as long as we can separate them, and that might be then that after all, in 6 months, 12 months, or a bit longer, it might go back to the old normal. See how we go. Now, it is definitely logistical, and you all know that better than me with your experiences. It's a logistical nightmare. It's very hard to do that, and the resource and costs are much higher. As I said, we opened the borders, and now we see how it all goes. Preparations have been done in hospitals and health services on all the fronts across the patient journey, from emergency to the theatre spaces, intensive care. They were on the forefront with their plans. Very important in making also statewide, in the statewide network, all the negotiations and pathways for and modeling as well throughout the state to make it happen. And then the ward movements as well, to really try to have two separate patient flow models through the hospital. On a statewide level, I just heard today that they started with this Get COVID Ready. Can you believe it? You probably not, because you're all over. But we have a lot of patients and community, consumers and communities that haven't been in touch with COVID infections at all. And yes, for sure, they're struggling to get the perception, and social media, it's everywhere out there, but personally what it means and how to really manage and cope. So there's lots of initiatives to engage with the community as well. The intensive care network is very proactive. So we have the ICU capacity, currently 437 ICU beds across the state. 2/3 are in the southern part, and then in the regions are only 180 beds. 108 beds, and with COVID plans we can expand, and if you also use the private and public relationship, you can expand even more. In the terms of the COVID trauma response, we've just submitted our escalation plan. We also started off with a trauma directors group in the state, very agile, just on a daily basis, that we communicate with each other, drop off ideas on a clinical but also on a operational basis, just to manage what's to come. And the last thing that Queensland Health is quite proud of is really a coordination hub. You see that's a bigger office space across the road where I took the picture from before, where you see lots of screens showing the whole state with what's going on pre-hospital, all the ambulances lining up as well, and then all the health regions, the map of Queensland, and then also the weather radar and news and anything else. But here you can see, zoom in, here you see there is really, the black one is one of the HHSs that is full currently. Yesterday there were 5, all hospital beds were full, so it's already a struggle. And we can switch also to the COVID updates, which is a live feed, so it's all dashboards with live feeds within 10 minutes. So how is the impact actually on trauma, on the management, on the patient as well? For sure, there is a direct influence if the patient has a COVID infection. And again, you are much more the experts about that. So we'll concentrate more on the indirect effects of going into the new normal. In terms of the journey, it's the pre-hospital and retrieval service, and that's part of where we need to concentrate, because we have a very dispersed population in Queensland. So for us, it's really logistical, quite a big deal. Just with retrievals, for instance, whether it's fixed wing or choppers, it's logistical, far longer times. So we need to clean the planes as well again, and it takes an hour or two sometimes for the next job. So it is really, that will impact. So we have to be much more clever and coordinate better. But we definitely still want to triage and coordinate according to clinical principles and priorities, but it might be difficult. In terms of pre-hospital times, yeah, there will be prolonged times. I have to say that our Queensland ambulance service system is very slick, and so there has been a lot of training, and yes, they are very used to wearing PPE and so on, because they had to assume during certain times of the pandemic that some of the patients might have COVID. In the emergency department, it's really the 2 streams with clinical priority, and here it's the risk stratification and assessment. That's difficult for us still, because we haven't seen that many, and it will change. So we have to watch and adjust that. Big communication issues that we see, and yes, again, you are the experts and we learn from you. We will have possibly some delays in getting used to the new COVID stream as well, in terms of diagnosis, management and transfer, and also hopefully not too much compromised procedures, including operations. With the operating theatres, we have a dedicated operating theatre ready in all the hospitals now, but yes, that has a reduced theatre efficiency. Staff is trained, but we are not familiar yet, so we have to do it with simulations and work on that. In ICU, it's really a competition with COVID patients. In the ward, I guess it's similar, but it's also particularly once the trauma patients with COVID infections go to the infectious disease ward, there will be a change as well. So we have to come up with models to treat them there, look after them there, and rehabilitation. There might also be a problem with bed flow. We have more and more rehabilitation units and beds. That's great, but then there might be a competition now with patients after COVID infections. They're still in rehabilitation as well. So in summary, we will enter a new normal. The predictions are that our case numbers will go up at around February and then definitely in March. Hopefully not too high. We will keep you in the loop. I think our plans and structures in place, they worked, and hopefully they will work in the future also with the new normal. It had impact throughout the journey. And yes, I guess we are excited, but a bit nervous whether it's how the impact will be and how the patient, the population, in particular the community, will cope. Because yeah, as I said throughout, we are actually not used to it yet. And so see how we go. Thank you very much.